I think the first thing as a patient presents with metastatic renal cell carcinoma is, if a patient is eligible for immune therapy, I think an immune combination is the most important. A patient who's ineligible for immune therapy, often due to a history of sort of poorly controlled autoimmune diseases, that is when we think about TKI monotherapy. And in that situation, I think the TKI monotherapies that are recommended by NCCN guidelines are going to be sunitinib, pazopanib, and in the case of intermediate or poor risk disease, cabozantinib. Given the CABOSUN data showing an improvement in response and PFS with cabozantinib over sunitinib, I think that I would prefer cabozantinib in these patients, especially when you look at the toxicity data from CABOSUN, that it overall is relatively comparable tolerability to sunitinib. At the end of the day, the NCCN guidelines are guidelines to help guide therapy. And I think, I would agree with those with intermediate or poor risk disease, given CABOSUN data for the TKI monotherapy. I think cabozantinib would be the preferred approach in that situation. Is there anyone who's unable to receive immunotherapy? It's a evolving field. There is data that suggests that even in the presence of autoimmune diseases, you can give patients immunotherapy. There's also data that shows, looking at those patients who are on steroids at the start of immunotherapy, there's concern that patients on steroids actually have a lesser response to immunotherapy. But when they went back and looked at some retrospective data sets, if patients were on steroids for an autoimmune phenomenon, not for disease-related complications, they actually still seem to respond to immunotherapy. So I think overall, this idea of, who can being unable to receive immunotherapy is sort of evolving. In my practice, if I have a patient who has an active autoimmune disease, I'm reluctant to do so. So if I have a patient who has a history of ulcerative colitis that has not required management for 10 years, I would certainly consider challenging immunotherapy or mild RA. But I've had patients come into my office who have severe RA with classic joint deformities that are having impact on their quality of life. And in those situations, I certainly do worry that by adding on immunotherapy, I'm going to exacerbate that further and have significant impact on their quality of life. So it really does come down to a balanced discussion with the patients. I think in renal cell carcinoma, we're fortunate that in patients who may have relative contraindications to immunotherapy, we have great alternatives in cabozantinib or the other VEGF targeted therapies.